Thank you for listening to the FND Society podcast. I'm your host, Erica Cotton, coming to you from Chicago. I have an excellent team, including Michael Romeo, our sound and production engineer, coming to us from Australia, and our content curators, Ingrid Hurritsauer from the UK and Chrisma Pretorius from South Africa. We also thank Megan and Robert for all their administrative support. This week's guest is Dr. Julia Das, the owner and director of Das Clinic of Health Psychology. This clinic is focused on providing care for patients with psychogenic non-epileptic seizures and other forms of functional neurologic disorders. She is a clinical psychologist with a pediatric specialization. In practice, she has focused the majority of her 20-year career on assisting in the diagnosis and treatment of patients and their families struggling with PNES. She has published her research in scientific journals and has authored professional book chapters and presents in meetings across the U.S. and abroad. She's been a chair of the Pediatric Non-epileptic Seizure SIG in the American Epilepsy Society, and she's currently a steward for the NINDS NIH Task Force for Comorbidities in Epilepsy for the past 5 years, from which recommendations were presented to Congress to assist in determining funding and research in this area. She was involved in the first pediatric multisite study of youth with psychogenic non-epileptic seizures, and she has co-authored 2 books, one in 2017, Pediatric Psychogenic Non-epileptic Seizures, a guide, and more recently, the Psychogenic Nonepileptic Seizure Pocketbook in 2023 with co-author Dr. Lorna Myers. Dr. Das has been a training director of psychology fellows while practicing at the Children's Hospital and Clinics of Minnesota. She is experienced in pediatric hypnosis and uses a wide variety of modalities when approaching the treatment of PNES. Dr. Das has trained a number of postgraduate clinicians in the treatment of PNES and functional neurologic disorders and enjoys disseminating information to clinicians. She and Dr. Myers have recently launched an online training program aimed at teaching clinicians methods for managing PNES in youth and adults. We discuss her pathways into FND, her views about FND subtypes, similarities and divergences between adults and pediatrics, the role of the family in pediatric FND, her views on terminology and its importance, the role of psychological service access and treatment models and structures within healthcare systems, and how that can be best approached and considered by treating clinicians. It was a very enjoyable conversation with such a skilled and seasoned FND clinician. I hope you enjoy this episode. Well, thanks so much for joining me today, Dr. Das. Let's get started with your background and how you got through FND and what brought you here.
Yeah. Well, thank you for having me. I'm happy to always talk on this topic. I've been in the field for about 20 years. And so I didn't start here, though. This wasn't my focus. Like many of us, I think, especially a number of years ago in training, there really wasn't anything about FND in my graduate program. I did my graduate training in Chicago and then kind of moved around the country and did training around the country. But my focus at that time and always really was I wanted to work with pediatrics and I wanted to work in trauma. So I was specifically interested in health-related trauma. But working in Chicago, I had the opportunity to work with a lot of kids that were in the social services program, foster care, and was really seriously directing myself in that direction for my career. But as training does, we end up going into rooms with people and meeting people that we don't expect. And on my fellowship, I was in a pediatric psychology fellowship program in Wisconsin. And it was a very large comprehensive program where we worked on a rehab unit, we worked on a PICU, NICU, things like that. And my primary supervisor, who was absolutely wonderful, loved working with the really, really little kids. So every teenager I pretty much got to see, and which was great because I love working with teens. But we had a patient one day who was on the rehab unit, and he was like, "This is going to be very complex. I know you haven't seen this before, but go on in there and see what you can do." I walked into the room and had no idea what I was running into. It was a patient who had non-epileptic seizures and had lost some feeling in her legs and was unable to walk. So she'd been moved to the rehab unit and had been there for a few weeks by the time they called psychology in for a consult. And but the patient had never been given the diagnosis. So she and the family did not understand that these were not epileptic seizures. They had a sense that they were not coming, and this is how they described it, coming from a brain problem. They, but they didn't understand what they meant. They didn't understand why they weren't on medication. And the physicians and some of the staff were very uncomfortable working with the patient because they were afraid if they told her too much about what they thought this was, that the family would get really angry and upset and leave the hospital. And it just would be a really bad situation for them in the hospital. And so my role was to kind of walk this line, never having worked with a patient with FND before, and hearing from physicians and staff that I should not reveal what this is. I should just be working on kind of coping with this really hard thing that was going on. And let's get you out of the hospital as soon as we can. And through that, kind of situation, I learned a lot of, I think, what not to do and a lot of kind of how complex it can be working with these families and these young people, and also how complex it can be working within this system. At that time, like I said, this was kind of like the early 2000s when I was on my fellowship, and the term pseudo seizure was still being used, kind of fading out, but still being used. There was not a lot of literature to look at. Within the peds world, there was almost nothing written about FND in peds. And so a lot of my learning came from just being with this patient. And then after this patient, seeing other patients that came in with it, and learning from them directly. And so from there, after my fellowship was over, I actually sought out a program in Minnesota with the Minnesota Epilepsy Group. And that is a comprehensive level 4 epilepsy program. And it's a referral center for kind of all the surrounding states. And so on our unit, we had 10 to 12 beds, and we would see 3 to 4 kids a week with non-epileptic seizures. And so my focus for the 15 years that I was there was very intensely focused on working with kids with non-epileptic seizures and other forms of FND, other movement and some of the other things that we see with FND. So that's how I ended up in the field. And then I, actually through American Epilepsy Society, became really involved in the task force there, and eventually was the chair of the SIG for PNES, and just met a lot of people, became involved in some research studies, and that's kind of how I came into this field and have continued the work. So
awesome. Thank you. Yeah, it's generally always I didn't know what I was even walking into, and then it becomes wow, well, this is an area that has so much need, is so interesting, and there's so much room for help, growth, expansion. It is not a saturated area of medicine.
No.
By any means. So that's great. Can you walk our listeners through your conceptualization, especially in pediatric patients, about any distinctions between seizure-like episodes versus movements versus dizziness and all of the sort of traditional, quote unquote, FND subtypes, and how those might present in kids, and if you see them more on a continuum or distinct?
Mm-hmm. I think for a lot of years, people were in these like different camps. It was kind of like the people that worked with the kids with non-epileptic seizures were here, and then there was the movement disorder stuff here. I've never experienced that with kids in those distinct ways. Like I think in many of the patients that I have seen and that I continue to work with, there's kind of a waxing and waning of FND symptoms, and what they initially present with is not always the only thing that they continue to have through the entire process. So I've never thought of them as distinct kind of subsections where you could only work with them in this particular way, and then this other type of symptom we work in this other way. I've really seen it as kind of a disorder as a whole. All these different symptoms are just symptoms, and in any one person, we're going to see a shift and change over time. With peds, we do have a tendency to see a lot of different kinds of symptoms. So it isn't common actually for them to start having, non-epileptic seizures and then move 3 months later into a more of a movement disorder paralysis. We'll see these symptoms kind of pop and come and go. And patients are often asking me, like, is this part of it? Is this something else? Is this another thing? It's like almost every time I see them initially, they will say, now I'm having this new thing that's come up. And so yeah, we do tend to see just a range of different symptoms. Some symptoms, in my opinion, are a little bit easier to manage than others, but that's just probably because they're some of the techniques that you can work with them on are easier for them to do versus some of the more challenging things. But overall, I kind of see it as all one thing, and typically as they improve, all of the symptoms improve. It's not just we get one under control and then this other one sticks around. Typically, as they improve, we see all of them improve. So
great. In the adult models that I'm familiar with, heavy involvement of multidisciplinary psychiatry, PT, speech, but in the adult world, more reliable for functional movement issues than non-epileptic seizures, which are more on the behavioral health side. Is that model mirrored in pediatric, or is it more ubiquitous access to PT, and speech regardless of symptom presentation?
Yeah, no, that's a good question. I see it significantly less in peds, that there are referrals to PTOT speech for any of the symptoms. So I would say with movement, yes, it's a little bit more often. With the non-epileptic seizure symptoms, almost never that they would be referred to to any of those subspecialties. I think there is a bit more of that happening now in the last few years, probably with the start of the FND Society. There's a bit more of those recommendations out there, and so I have seen it a little more. But I would say still within the peds world, the most common recommendation is to go and seek out a therapist and do cognitive behavioral therapy. When I have worked with kids who have been in PT, sometimes what will happen is that they go and that's the only thing they have. And so it's sort of the referrals, the way that I've seen it play out is that they will be referred to a subspecialty, see how that works. Then we'll try this next subspecialty rather than here's all of the options you have. And here's some ways that we can approach this with a range of different techniques. Which I think is not great, because then people can continue to experience some pretty severe symptoms for long periods of time without, for example, coming in for any kind of mental health treatment.
So it's more like a linear or fragmented process or sequential kind of process than a comprehensive multidisciplinary approach that is all occurring at the same time.
Yeah.
Okay.
That's been my experience. Yeah.
Oh, I don't know if I'm more or less surprised. I would have thought in peds there would be more involvement, but I guess
that has not been my experience here. It might be different in other parts of the country, but that is definitely not my experience here.
Okay.
And I'm in Minnesota, so for the listeners.
in our Midwestern section of the country.
Right.
It's very cold this time of year here, just Midwestern snow, cold corridor. That's a great segue into our next set of topics that I'm very, very eager to hear all of your thoughts about and share with our listeners and start to introduce discussions, partly involving any differences or just in general what the conceptualizations are regarding comorbidities, especially psychological comorbidities within a pediatric FND population. And I think this also then touches on nomenclature and diagnostic labels. And I'd be very eager to hear, especially given the span in which you've been in this field, how these things might have evolved and shifted over time.
So peds, and when I say peds, I'm not just talking about, young ones like under 10. I kind of conceptually think of them as, under 21 really. But mostly kind of in that mid-teenage 14 to 16-year range, which is kind of like the average onset for if young folks are going to develop this disorder, they will develop it around 14, 15. That's when we tend to see many of them coming in. A number of years ago, I was involved in a study where we were looking at the risk factors for peds. And what we found in that study was that the risk factors, or the factors that led to the onset of this disorder, were much different than what we see in the adult population. Within the adult population, there's such a large history of trauma, and much of that is sexual trauma. There's a much greater preponderance of women who have it than men. That is not the case with peds. There are more young girls that develop this disorder, but it's a little bit more even in the split between male and female who develop the disorder. And the factors that we found in the study were not, it was kind of like, I think of it as like a layering, a layering process, meaning there's many different stressors that kind of like contribute. And then it's like the straw that breaks the camel's back, and then the person develops symptoms. And so some of those layers, some of those stressors are really, bullying was one of the main things that we saw. Now, of course, bullying can be traumatic. It's different than sexual abuse trauma, but it can be traumatic, of course. We saw other co-occurring medical illnesses as being a really significant, risk factor. Co-occurring psychological struggles were incredibly high in our study. With I think it was close to 100% of them had a co-occurring anxiety or depression. And so, but most of the time in peds, those like the anxiety and depression have not been previously treated. Mm-hmm. And what we also found in that study was that parents were largely unaware of their kids' emotional struggles. And so with only, I think 10, or don't quote me completely on this, but it was 10 or 12% of the parents who were aware that their kids were experiencing anxiety or had been experiencing depressive symptoms. So those were some of the factors that we saw that led these young folks into developing the disorder. And when they were receiving the diagnosis, the FND diagnosis, sometimes that was the first time that the parents had heard my child struggling, not just with these physical symptoms, but also some emotional struggles. And also some of those risk factors that we talked about, like the bullying or difficulties in school or, things like that. That was the first time sometimes that they'd heard of that as well. So it's kind of a shocking diagnosis for a lot of people, I think adult and peds, but in the peds population, it's kind of like, here's this diagnosis, and here are some of the possible reasons this developed, which is a range of things that can feel really overwhelming to people when they hear for the first time, especially parents. So I know that in the adult population, people come with partners and caregivers when they have this disorder. But in the peds population, that is always present. So the way that I kind of conceptualize working with these families is very much from like a family systems and the standpoint. I do not ever see a young person where I also don't interact and kind of train and treat the parents or caregiver, because there's just not any way that we can expect the symptoms to improve if we don't do that. And so those are just some of the differences in the ped and adult population. And I think that there's still quite a question among a lot of folks when this is first diagnosed, like, oh my goodness, my child's been traumatized, like sexually or physically by someone, and we don't know. And that's not the case. Certainly that can be a factor for some folks, but it's not actually higher than the normal population of kids who experience physical and sexual trauma. So it's not a specific risk factor in the peds population is what I'm trying to say. So
Yeah, that's very helpful. Forgive maybe one ignorant question on my part,
okay.
being so out of the peds literature and so in the adult. And I bring this up because you mentioned very high rates of comorbid anxiety, depression, and then family unawareness of that. I guess what came in, the question that popped into my mind was in the adult literature, especially with current mechanisms, there's a big emphasis on alexithymia as a central regulatory, dysregulatory mechanism with lack of emotional granularity, leading to dysregulated physiological processes, agency, et cetera, body awareness, all this, with addition to Bayesian predictive models, which that's a whole different podcast. But regarding alexithymia, my thought in this was in kids and in adults, I think it's hard. A lot of patients initially have a much greater difficulty recognizing. Some come in and say, I'm stressed, I'm anxious, and I can totally tell, and my symptoms are connected with stress. Other people say, I'm not stressed. My neurologist said that this is because of stress, and I'm not stressed. So tell me why this is happening, right? And I wonder in kids, is it that children are aware of their emotions and the family system is not integrating those emotions, and they're aware, and I mean in an age of appropriate way, right, to the level that we wouldn't expect a child to have the same emotional awareness and regulation as an adult. But is there an atypical emotional awareness that is also present in the pediatric patient themselves, or is it a sort of pseudo-systemic alexithymia based on the family system? And I don't know if that question even makes sense or is,
Yeah.
if you have
No,
thoughts on that.
it does. Yeah. No, and we do see alexithymia in the peds population. I think one thing that the way so kind of to answer that last part of your question, yes, there is a systemic issue with that.
Mhm.
I think in many of the young people that I have treated, they do present in the exact same way. I don't understand why everybody's telling me this is stress, or I was watching a movie with my best friend and then I started having these seizure like things, and why would I be stressed in that environment, right?
Yep.
And so helping them to understand that that's just not always how stress presents itself. But what I will say is that there's a definitely in the peds population this interplay between patients, the pediatric patient being able to express what their emotion is and how the family accepts it. And so, and recognizes and understands it. And so some of that is alexithymia on the part of a parent or both parents. And other times it has to do with a kind of what I've seen is sort of an overgeneralization. Parents kind of go through their experience and assume they understand how their child is experiencing the world, and that which we all do as parents. I mean, all of us do that. But in some of these cases, that young person who struggles to maybe understand their emotion themselves very much struggles with being able to communicate when they feel an emotion that's divergent from what they perceive their parent is perceiving, if that makes sense. And so one of the parts of this therapy is communication based, like helping people to not only recognize those emotions, but be able to kind of communicate them to each other and tolerate the differences, which again, that gets into all of this like kind of family systems theory stuff, which we probably don't have time for, but that's kind of a huge part of the process. With the pediatric patients, in my experience, often recognizing their emotion better and earlier than, but not being able to express it in the treatment. So, yes, alexithymia, but maybe alexithymia light, and then from the parents, maybe more of that. So, yeah.
That's fascinating. And it just strikes me as such an amazing opportunity to intervene so early, right? Because I'm on the adult side where a patient has already lived through a negative family experience with their emotions, where common themes are, my family didn't mention, you didn't have emotions in my family. Like
Right.
either you didn't have it or you had the one that they wanted you to have, but it wasn't, Mr. Rogers' feelings are mentionable and manageable,
Right.
in that family system. But in an adult world where I'm seeing someone, who's in their 40s, there's nothing we can't go back and change that experience or develop that. So we're kind of working with what's already happened. But in the peds, it sounds like you can intervene early enough so that that maybe completely internalized alexithymia is not solidified that early.
Right.
And that then you can change the family system and create a lot. I imagine the outcomes are able to be much more long lasting, and you're just reducing. I wonder how, again, we could do a whole different podcast on longitudinal studies in pediatrics and lacking longitudinal studies in FND, but that would create such better outcomes for children
Mm.
addressing that early, in the later decades, just being at reduced risk for then some of the later issues that people who grew up in more dysfunctional families without intervention, if that makes sense. Because we know
Mhm.
that that's connected to a whole host of mental and behavioral health issues and physical health issues.
Right. Right. Yeah. Yeah, I can't agree with you more. I think that that's very true. When you're able to intervene in the system as the system is being built, it definitely has a much uh, a greater ability to have a lasting impact on some of that. So,
Now I'm very
mhm.
jealous of the work opportunity. I'm like, oh man, oh, there's a whole group of opportunity to help people. On that note, though, I think it's helpful because you mentioned this is kind of the first time families are hearing about a lot of these aspects, and they're struggling with, we don't understand this. What's happening? Why am I seeing a psychologist for a neurologic issue? And you've lived through professionally kind of the development of how neurologists make the diagnosis, how they talk about it, how we as a field are talking about it. Love to hear all of your thoughts and beliefs on that. And I think it's really important that we have these conversations and that we are self-reflective as we're going along in our current stage.
Yeah, such a complicated issue. There have been a number of moments in the history of this diagnosis where, um, I mean, looking all the way back hundreds of years, honestly, at kind of the way that it was labeled, the way this disorder is labeled has such a significant impact on the way not only physicians approach the patient with the disorder, but how the patient conceptualizes what is happening to them, which I think is the most important part.
Mhm.
The psychological processes surrounding this disorder, um, I, are very complicated. It's in the population of people that I have ever personally treated. Folks with FND have so much psychological complexity, and but also can have such great outcome if they understand it. And so I think that you know in the time that I've been working, like I said, when I had my first experience with this, when we were still sort of calling this pseudo seizures, that I'm just going to use that particular set of symptoms as a descriptor because it's just easier for me since I've done a lot of work in that area. Pseudo seizures, you know, that label was really pejorative. It was fake seizure, and it engendered in both physicians who were giving that diagnosis and in the patient that somehow these symptoms are fake and intentionally produced. That was the assumption a lot of the time. And naturally, when people are interacting with someone who's doing something that's quote fake, you're going to approach them differently. You're going to speak with them differently. You're going to try to assist them differently. You might be annoyed with them. You might be afraid of them. You might be just really uncomfortable in the room with them. And then the patient who's been given that information either takes that on and then feels this burden of, how am I faking? Why am I faking? Uh, and feels overwhelmed, or they become angry about it and react to it. And then the interaction between, professionals is professional and patient can be really negative. And I think that's where I started. That's the place I started. And then shortly after that, when I really kind of got into the field and started working with some of the researchers, the shift into calling the seizure-like symptoms psychogenic non-epileptic seizures, there was that shift. And there was a lot of emphasis on how do we sit down with the patient and describe this? How do we help them understand the psychological processes that might be at play in this, and why that's an important component of treatment? And why it's important for the physician to stay involved, and why you might need a psychiatric nurse practitioner or a psychiatrist. Like, why are we having all these different components? That was part of the explanation. And the term psychogenic non-epileptic seizure kind of lent itself to the patient understanding there's a psychological component. It's not epilepsy. And so it's not something that I have to be thinking about as a potentially chronic neurological condition. And there's these different kind of providers who are going to be involved with me to help me like kind of move through. So that was kind of the bulk of the time, from, 2010, 20 around there to like 2020, where we were really, that was kind of the terminology, and that was sort of the way the messaging was given to patients. And then in the last few years, there's been the shift, pulling into the FND group and being able to kind of see like, oh, it's not just non-epileptic seizures. It's also movement. It's also, something that might be looking like Tourette's. Like, there's all these different sets of symptoms, which in my experience, I'd always realized that was all part of it. But now we were actually part of groups that were like recognizing that and working on it together. And there has been a shift in terminology. And the shift in terminology continues to be debated. I think, recent papers have come up with different ways of approaching it. But one of the shifts that I've seen that I will, frankly say I'm worried about being in the field all this time is that there seems to be a pulling away of discussing the psychological parts of this and how that might be at play. Not that it's at play for every single patient, but how it might be at play for a vast majority of patients, and why they need to see a psychologist or a mental health provider in the first place. So when a patient gets that diagnosis of FND, functional neurological disorder, a number of patients recently have been coming to me with this feeling of, I have a neurological disorder, not a psychological or psychiatric disorder. So why am I seeing you? So this question that I had gotten, 20 years ago is resurfacing very, very frequently, almost in every patient now. And even if it's being described somewhat in the feedback, the messages that people have shared with me have been, I have this neurological disorder that is likely going to be chronic, and that's really overwhelming to me. So like, help me cope with that. Help me cope with overwhelming diagnosis. So that's always a part of managing this diagnosis, of course, like helping them cope with the diagnosis. But so much of what we do, or what I do as a psychologist, and what other mental health providers do, is treat the symptoms, help the symptoms move toward a remission. In pediatrics, we have huge success rates with that. Kids can go on, I have so many stories of kids like completely resolving their symptoms and going off to college. It's like that happens. But when folks come in and they have a belief around the symptoms that they will never go away, or they'll maybe get less, but, might come back in 2 months or things like that. That is a really, really different psychological process in learning how to manage them, feeling safe in their bodies, and being able to trust that they can kind of push towards this place of resolving those symptoms. And so yeah, the shift, and the terminology is not the only shift. I think there's a shift in how we're explaining it,
Mm-hmm.
and that is resulting in confusion. And so, and I know there's many, many reasons for the shift. I understand the reasons for the shift, but I worry about some of the outcomes if we go too far down the path and don't recognize that some of these things are now happening.
Yeah.
So
That's very helpful, and I think it's a very useful perspective and reflective point as we as a field are evolving our diagnostic labels, directions, communication patterns, trainings, right? Like let's be sure that we're
right,
also portraying the right message to people we hope continue to help people with FND. One thing that comes up or was playing through my mind through this, or the question was, is it, do you think, I mean, it makes perfect sense that if psychological is lost from the diagnosis, that's going to be a harder, there's no entry point to then begin to have that discussion with patients. One thing that came to my mind was, do you think the issue is related to, or how much we need to address the issue of this? There's dualism with mind and body, right? But I feel like there's a dualism in medicine now of neurology and psychology, right? As if those are somehow very distinct, separate things. So do you think that it's more of a we need to decrease it or continue to emphasize the psychological, or do you think we need less walls and divisions between those disciplines to say that psychological is neurological, it's just on a different scope and scale and has a greater likelihood of flexibility, right? Because there are plenty of psychological conditions that are not flexible, right? But that's probably due to underlying structural or chemical differences that are more resistant. But it also begs that question of saying, I've heard this explanation or this common explanation of it's software, not hardware, right?
right,
And but lots of neuroimaging studies are suggesting that at some point, if you run a software enough, it becomes hardware, right? And this kind of possibly unhelpful distinction. So what do you think would be a good solution? Is it we need to change the way that we approach even discussing neurology and psychology? Or are these silos helpful and do we need to continue to work in those? Because there's arguments that could be made of
mm-hmm.
conceptualizing this as psychological, quote unquote, is helpful for then practice management, practice development, right? Because then we approach populations with high psychological and psychiatric complexity administratively, from a systemic level differently. There's different resources utilized, different levels of support, different safeguards that are in place that I also agree I worry might be missed in this population if it's just all perceived as this is purely neurologic. Any symptom, cognitive process that this person, cognitive meaning psychological or emotional process,
Mm-hmm.
I think it's all coming from the brain, right? And that they have is related to a neurologic condition, which then might leave providers who are developing programs or practices not equipped, or for systems not to recognize the level of support, staffing, et cetera, that this complex population might require. So I know I just put a lot out there, but I just would be very eager to hear your thoughts on any or all of it.
Yeah, yeah. I think it's very complicated, and I don't feel like I don't know that I can answer really succinctly all those questions in one response. But what I will say is that I think that the move away from recognizing that the brain as housing everything, both the hardware and the software, the neurology and the psychology, psychiatry processes, is very problematic. I tell this to my patients when they come in and they have these questions, and I say, well, everything that affects you physically affects you emotionally, and everything that affects you emotionally affects you physically. We have tried so hard in our culture to separate out these things and kind of create an understanding of one thing is more legitimate than the other. If you have a brain problem, that's a real problem. But if you have a psychological problem, a mind problem, there's a lot of stigma around that. That's really hard to address. People are afraid of it, frankly. They're still afraid of it. And the more that we separate it out and kind of keep these things in there, and delegitimize the emotional processes that are at play within this population and this disorder, the harder it is for them to get treatment that's good treatment. And I think that both are valid. The neurological process is happening and the psychological process is happening are valid issues that need to be addressed within this group. And they won't be unless it's kind of woven together. And we see that in other areas of psychology, psychiatry. There's these kind of pendulum swings from kind of looking at the mind body together to pulling things apart again and then putting them back together. And I see this as kind of a pendulum swing within this group too. But the times I think when we've seen great patient care in this field as well as other areas of psychology is when we understand that everything that's happening to us emotionally comes from our brain for a variety of different reasons. And we can't be afraid of that. We have to destigmatize that, and not talking about it doesn't destigmatize it. And that's my worry. Not talking about it, being afraid to talk about it is not the way. Being afraid to offend a patient. I hear that quite often and I read about that quite often in some of the more recent articles about how offensive it is to be told that you have a psychological component, that there's a psychological component to what's happening. I can say in all honesty, and I know I'm a psychologist, so I'm really biased, and I'll acknowledge that. But I don't experience that when I talk with patients about this. When I used to work on the unit and walk into the room with the physician and we deliver the diagnosis together, which happened most of the time for the 15 years that I was there at Children's, we didn't run into that. People weren't angry at us. But it has everything to do with how you explain it. I really believe that. And yeah, I'm working with kids, so I can say peds might be really different than how adults experience this. But I think, at least from the pediatric population, that was my experience. And I think it had everything to do with, we had physicians who were really thoughtful and very, very open to sitting with a patient, sometimes for a really long time, to make sure they understood it. And then I was there too, and I had the experience too. And we would just, all of us talk together. And that was just a really great way to kind of bridge the, diagnostic to the treatment. So I don't know if that answers your question exactly, but that's kind of like how I think about it.
Yeah, if I could reflect maybe partly what you're saying, which is that in a good intentioned effort to reduce stigma for FND and kind of legitimize FND, pulling it to a neurologic explanation where here's the underlying brain patterns, here's this neurologic, this real thing that's not faked, it's not malingered, that by pulling so hard in that direction and not including at least initial discussion of psychological components has a multitude of additional outcomes, but in some ways then reinforces, by trying not to stigmatize FND, you're actually stigmatizing psychological processes and mental health.
Right.
and then leading to a system that then is creating one set of diagnostic expectations or understanding on one side that then is kind of, oh, but here, go see this other person to actually work on these issues, which it could sound a little more underhanded, right? Which is we believe that there are these psychological components, but it's not included in the diagnosis because we don't want to offend people or increase the stigma. But then why is psychological stigmatizing, right? That sort of begs that
Right.
question. And
Right.
and and I
Right.
think this is a really complex, this obviously extends beyond FND, but it's so the unity of these neurologic type symptoms with an underlying psychological process is so uniquely present in FND, right? And in a way that is not as, although, we see it in, a panic attack. One could argue that
Right. Right.
people who are having a panic attack, their nervous system is not working so well in that moment, right? Or is slightly
Right.
dysfunctional, due to what we would all agree is a psychological quote unquote process. So I think those points are very well raised, and we should be thinking carefully about how diagnostic labeling, if our diagnostic labeling is serving to create a broader division, or if it's serving to create a unified understanding of neurological and psychological processes that's helpful not only for this condition, but for the broader field of, you know, medicine, medical practice, but also kind of societal views about, why is it that families don't talk about emotions, right? Like, or why is it that our culture,
Right.
that we don't is that
Right.
part of it, if that makes sense.
Yeah, absolutely. Absolutely.
Yeah. Well, I'm with our last little bit of time here, I'm wondering if you could tell us a little bit more about where where you think the field needs to go in terms of research, and especially for the pediatric population, if there are any kind of burning issues about awareness of pediatric FND, incorporating that into training for providers or the medical systems, and kind of burning next directions to keep things moving in a good direction.
Right. Right. I mean, I think we need a lot of research into peds. And that, there's some things getting started now, looking at treatment. That's wonderful. We need to look at long-term outcomes. We don't have any of that at all. I think I think one thing that's incredibly important is reaching into training programs. I think this is likely true for adult too, that there shouldn't be times now where neurologists go into a room and have never really gotten any training. There shouldn't be times where psychologists go into a room and are expected to treat FND and have never really had any discussion
Mhm.
of that in their graduate program, let alone, kind of on going into their internships and fellowship programs. So, I mean, I think that the research is just wide open for peds. Like really any area of peds, anything that's been studied in adults should also be studied in peds. And we need to just like kind of broaden our scope of understanding with this young population, recognizing that it is different than the adults, and um, then the outcomes are different, and that's important. I can say that anecdotally because I've done this for a long time and seen a lot of people, but that doesn't mean anything if it's not in a research, if it's not well researched, and we don't have, good long-term longitudinal studies that recognize that there's a difference, and we need to understand what that difference is about, why. And I think that understanding treatment and kind of the best methods for kind of approaching the disorder and then treating it should also be studied. We need to know, should every person be getting PT? Do we
Mhm.
need, when is it really important that they get referred? And then what are the other, kind of subspecialties that we need to get involved? Um, and I think that's very important for peds. But probably one of my kind of current passions, and I hope a lot of the people in the field recognize, just training other people to treat this is so important. Even, we can diagnose this well now. We understand it in that way for the most part. But we we still don't have a lot of people to refer to.
Mhm.
And there's more and more interest. But I think there would be even greater interest in more comprehensive studies if we started early and got into training programs better than we are now. So I think that's where we need to go.
I'm
Mm.
curious in pediatric world, because I went through the adult cycle here, which is odd. And for our listeners, pediatric and adult trainings usually have a pretty marked divergence. At some
Right.
points,
Mhm.
we just have totally, even from a doctor, I remember starting my doctor, be like, you have a peds track and you have an adults track right
Right.
from day one. Like
Right.
this is how separate we view these people,
Right. Right.
these sets of humans. And I know in my training and experience, there's kind of one realm that's psychological pieces, right? Anxiety, depression, bipolar, all those. And then there's one realm that's neurological, which obviously as a neuropsychologist, I got heavily involved in, strokes and seizures and, traumatic brain injury and MS and the neurodegenerative conditions. And then these kind of classic neurologic conditions that as a neuropsychologist, we have to be aware of. But in neither of those camps was FND, right?
Right.
It wasn't in either. And I'm in the adult world, that's all I can speak to.
Right. Right.
Is that the same in the pediatric world in your experience?
Yes, it's identical to that. Yeah,
Mm,
it's identical to that. And I think the message that I received from my training director at my fellowship was, "Oh, this is just really rare. So that's
yeah.
why you didn't learn anything about it." And it's really not, right? We all know that it isn't as rare as everyone has thought.
Mhm.
And people run into it all the time. And so it's interesting that within the psychological world, it hasn't been picked up as
Mhm.
this is a legitimate thing to study and train
Mhm.
people um, in the same way that it has also been kind of pushed a bit to the side in the medical world.
Mhm.
So these folks are not, you know, it's really interesting, kind of fascinating actually, that this kind of merging of the two worlds, the neurology and the psychology, within these patients has in both fields, nobody's picked it up. People haven't picked it up as like we should champion this and we really need to be studying this. And um,
Yeah,
so
I think a few more neurologists are these days. I think because we were just looking at the last membership numbers for the FNDS, and there's definitely more neurologists. But I agree, and one concern that I have, obviously, I don't have a concern that neurologists are interested in this. By all means, yes, please, everyone,
right,
everyone be interested in this. Everyone,
right,
your
right.
grandmother, bring her too. It's like it will be fun. We can use all the help we can get, but
Mhm.
by not. And I agree. I think this is where if the psychological component is de-emphasized, I slightly also echo some of your worries about are we then missing an opportunity to utilize well-existing structures and processes and pathways for complex psychological patients that create more support for patients, more support for providers that would increase access and accessibility. And a part of me also wonders that the reason for a provider shortage of treatment is psychological providers hold a stigma against FND.
Mhm.
And in some ways, that's unfounded, right? These
Right.
patients can be very, very rewarding to work with, and there's lots of great outcomes, and it's not all chronic, certainly not malingering, right?
Mhm.
But I
Right.
think there is this component of it. Well, those people are really complex, and my colleagues say, well, any FND patient, they're just always complex. I'm like, well, that's just this is just that population. That's not, you know, and if this was regarded as something where, yes, if the psychological complexity was acknowledged and then integrated into the expectations for training and practice, right, that then this is the standard in which we set up clinic systems practices to respond or to help providers help these patients, that might be reduce the barriers for providers' interest and access and training and talking about some of those harder stigmas with providers and saying, yeah, some of these numbers are scary for patients, right? Very high rates of personality disorders in this population. Let's talk about what that actually means. What types, what are present, what are the how does that interact with symptoms, and how does your beliefs around that change whether or not you would approach treating these patients, and the structures and supports and systems that might be helpful to reduce those barriers, because that's a lot of the pushback that I've heard from my colleagues is either it's faking, they're too complex, or it's all personality disorders, which I'm just like, oh, but that's they're just they're missing it. There's small kernels of truth in all of that, but they're missing so much about FND and what the patient population is really like and what
Mhm.
impact we can have as providers. But maybe that's my own soapbox that I just went on.
No, I agree with you. I mean, I think with anything, if we don't get exposed to it, we have a tendency to be afraid of it
Mhm.
or feel like it's too hard or complicated. And I think I think with exposure, we start to recognize patterns, which comforts us as humans.
Mhm.
We recognize ways that, you know, we can be with, as a psychologist, ways that we can be with those people, and we aren't going to develop that unless we're exposed to it. You can't really read about this and really understand it. I don't think you have to really be with people and understand it from their perspective. And so,
Yeah.
yeah, that has to start kind of analogous to what we were talking about earlier with intervening with peds when they're young
Mhm.
and in training
Training.
with their parents. It's the same when we are coming up in our programs.
Mhm.
If at the foundation we are learning, then we can there's a scaffold for us. But if we don't get that, then we aren't going to make choices to work with this population as easily. And so I agree with you. I think what you said is very accurate.
Yeah, I've had trainees who probably had some of those stigmas, et cetera, although they did a rotation in neuropsych with me, so they didn't hold all of them, hopefully, if I taught them anything. And they did a few rotations where they worked with patients with FND. And even in a psychotherapy context, I said, that was actually really rewarding. Like they were shocked that it was, and that's the common feedback that I hear from people is you can make such a difference. And in some ways, it's actually a pleasure to work with people with FND because from a psychological perspective, the therapy can be really fast in ways that it's not in other psychological conditions, right? Because you're not working through layers of defenses and these competing behavior. It's just what are your emotions, label them, learn to manage them, and they go home, they do the homework, they come back, they say that worked so much better. I'm going to keep doing this. And the progress that can be made is remarkable and life-changing for people in a way that in other rotations for more typical quote unquote mental health conditions like anxiety, depression, or other aspects were in some ways harder therapy relationships, which is mind-boggling to them that, that treating the anxiety or depression, the person with those conditions was harder in some ways than the amount of progress or impact of a similarly, actually sometimes shorter treatment relationship with patients with FND. And I agree, I think it's partly exposure and opportunity, and then also realistically addressing, yes, sometimes there are complexities and challenges, but here's how we manage those. If those elements are present, here's how we manage them. And here's the supports that are in place to manage them as a professional and as a system. But just, yeah, enough people having that experience to be like, oh,
Mhm.
we can do this, and this does work. And it is incredible to be able to be a part of someone's journey in that way. But
Yeah. Mhm.
oh, it's such a pleasure to talk to another mental health provider. I think I've
No,
been
it's been great.
our podcasting world is diverse in the range of people we get, but I really
Mhm.
appreciate your perspective. Any last minute thoughts or ending remarks for our listeners and our broad audience?
Um, well, I thank you for having me on, and I think I felt like a bit like I got on a soapbox today as well, but I also think where we are the people who can advocate for these patients, and it's been my life's career and passion. And so I just encourage people listening who are interested and who want to do this work, maybe haven't jumped in yet. It's just get yourself out there and learn, and connect with some of us that have been around for a while. And I think we can make great strides in this field. I'm excited to see where it will go. And yeah, that's kind of the end.
Awesome. Well, thank you so much for your career's worth of work in this field and for this population, and importantly, for being a thoughtful observer and participant in future directions and evolving elements of the field. I think it's really important that we maintain thoughtfulness around the directions we're heading and how we're approaching these elements and having these conversations and discussing these components. So it's not just oh, we did it, now we're done, and it's an active process, and it's very important, I think, that we maintain self-reflection. Spoken like true psychologists, aren't we?
Right.
Maintain self-reflection as we go about our change. Oh, well, it's been a pleasure. Thank you so much. I'm sure our listeners will really enjoy this as well.
All right. Thank you.